Congenital syphilis represents one of the most preventable, yet rapidly increasing infectious diseases affecting newborns, with the dramatic rise in cases reflecting broader public health challenges that extend far beyond the infection itself. The staggering increase from 1,306 cases in 2018 to over 3,700 cases in 2022 represents nearly a tripling of incidence in just 4 years, marking this as a true public health emergency that demands immediate attention from all practitioners caring for pregnant women and newborns. Understanding transmission rates based on maternal disease stage helps predict fetal risk and guides the urgency of treatment decisions. During primary and secondary syphilis, when bacterial loads are highest and active lesions provide maximum infectivity, transmission rates reach 60 to 100%, meaning virtually every exposed fetus will become infected. Early latent syphilis, typically within the first year after initial infection, still carries substantial transmission risk at 40% because significant bacterial burden persists despite the absence of clinical symptoms. Late latent syphilis shows dramatically reduced transmission at only 10%, reflecting the body's partial control of bacterial replication over time. The risk factors paint a clear picture of health disparities and social determinants that drive this epidemic. Lack of prenatal care prevents early detection and treatment, while substance abuse often correlates with high-risk behaviors and poor healthcare engagement. HIV co-infection creates particular vulnerability because immune suppression accelerates syphilis progression and increases transmission likelihood, while also complicating treatment regimens and monitoring approaches. Treponema pallidum demonstrates unique characteristics as a spirochete that make it particularly devastating during pregnancy and fetal development. Unlike many other bacteria, this organism possesses the remarkable ability to cross the placental barrier at any point during pregnancy, making no gestational age safe from potential transmission once maternal infection occurs. The relationship between timing and severity follows a predictable pattern where earlier fetal infection produces worse outcomes because the developing organ systems lack the structural integrity and immune competence needed to limit bacterial dissemination. When infection occurs during the first or second trimester, it coincides with critical periods of organogenesis and rapid fetal growth, allowing the spirochetes to disrupt normal developmental processes and establish infection in multiple organ systems simultaneously. Placental examination reveals characteristic changes that reflect the inflammatory response to spirochete invasion. The placenta becomes enlarged and pale due to chronic inflammation and edema, while phanecytis indicates inflammation of the umbilical cord that suggests ascending infection or hematogenous spread. Necrotizing velitis represents direct tissue destruction within the placental villi, compromising the maternal-fetal interface and potentially affecting nutrient and oxygen transfer. The multi-organ involvement pattern explains why congenital syphilis creates such diverse clinical presentations. Spirochetes show particular affinity for highly vascularized tissues, leading to preferential involvement of the liver, bone, central nervous system, and skin. This tropism for multiple organ systems simultaneously distinguishes syphilis from many other congenital infections that may show more localized patterns of involvement. Early congenital syphilis manifestations reflect the systemic nature of spirochete infection and the inability of the immature immune system to contain bacterial dissemination effectively. These signs typically appear within the first 2 years of life, though many become evident within the first few months as bacterial loads reach levels that overwhelm developing organ systems. Hepatosplenomegaly occurs in 70 to 90% of cases because the liver and spleen become primary sites of extramedullary hematopoiesis and inflammatory response to spirochete invasion. The hepatic involvement often progresses to frank hepatitis with jaundice, reflecting direct hepatocellular damage and bile duct inflammation that can compromise liver function significantly. Rhinitis, known as Snuffles, deserves particular attention because it represents one of the most infectious manifestations of early congenital syphilis. The nasal discharge contains massive numbers of spirochetes, making these infants highly contagious to anyone who comes into contact with their respiratory secretions. This finding should immediately trigger isolation precautions and urgent evaluation for congenital syphilis. The skin manifestations follow characteristic patterns that help distinguish syphilis from other causes of neonatal rash. The maculopapular rash typically involves the palms and soles, areas that are classically spared in most viral exanthems, making this distribution pattern virtually pathognomonic for syphilis. Bullous lesions in these same areas represent more severe skin involvement and indicate heavy bacterial burden. Bone involvement creates some of the most painful aspects of early congenital syphilis. Periostitis and osteochondritis cause significant discomfort that manifests as irritability and reluctance to move affected limbs. Pseudoparalysis of Parrot represents apparent paralysis of an extremity due to pain rather than actual nerve damage, named after the physician who first described this phenomenon in congenital syphilis. Radiologic examination of long bones provides crucial diagnostic information in suspected congenital syphilis because skeletal involvement occurs frequently and often provides the most objective evidence of infection in otherwise asymptomatic infants. Long bone X-rays reveal characteristic patterns that reflect the inflammatory response to spirochete invasion of growing bone. Metaphyseal lucencies appear as dark bands near the ends of long bones where active bone growth occurs, representing areas of bone destruction and impaired mineralization caused by bacterial invasion and inflammation. These lucencies create the distinctive celery stalk appearance because the irregular bone destruction resembles the fibrous texture of celery when viewed on radiographic images. Periosteal reactions manifest as new bone formation along the outer surface of the bone shaft, creating a layered appearance that reflects the bone's attempt to wall off infection and repair damage. This periosteal new bone formation can create significant thickening of the bone cortex and represents one of the most reliable radiologic signs of congenital syphilis. The Wimberger sign specifically describes bilateral erosions at the medial aspects of the proximal tibial metaphyses, creating characteristic notching that appears pathognomonic for congenital syphilis. This finding occurs because the rich blood supply to this area makes it particularly susceptible to spirochete invasion and subsequent inflammatory bone destruction. These radiologic findings appear in 60 to 80% of symptomatic infants and may represent the only objective evidence of infection in infants who otherwise appear normal. The osteochondritis causes significant pain that can interfere with normal movement and feeding, while severe cases may progress to pathologic fractures through areas of weakened bone structure. Late manifestations of congenital syphilis develop after 2 years of age and represent the long-term consequences of untreated or inadequately treated early infection. These stigmata result from chronic inflammation and tissue destruction that occurred during early infection, but required years to develop into recognizable abnormalities. Hutchinson teeth and mulberry molars represent pathognomonic dental abnormalities that occur because spirochete infection during tooth development disrupts normal enamel formation. Hutchinson teeth appear as notched, peg-shaped central incisors with characteristic indentations, while mulberry molars show irregular cusps that resemble the surface of a mulberry fruit. These dental changes provide permanent evidence of congenital syphilis infection, regardless of current serologic status. Interstitial keratitis develops as chronic inflammation within the corneal layers, causing pain, photophobia, and potential vision impairment that can progress to blindness if untreated. Cranial nerve VIII. Deafness results from spirochete invasion of the inner ear structures during development, causing sensory neural hearing loss that typically becomes apparent during childhood when speech and language development reveal auditory deficits. The skeletal stigmata reflect chronic inflammatory changes in weight-bearing bones. Saddle nose deformity occurs when chronic inflammation destroys the nasal bridge cartilage, creating the characteristic sunken appearance. Saber shins develop from chronic periostitis of the tibia that causes anterior bowing and thickening, while Clutton joints represent painless joint effusions, typically affecting the knees, that result from chronic synovial inflammation. Neurosyphilis remains rare in congenital infection compared to acquired adult syphilis, but when it occurs, it can cause progressive neurologic deterioration, including developmental delays, seizures, and behavioral abnormalities that may not become apparent until school age. Maternal syphilis screening employs a two-tiered testing approach that combines screening tests with confirmatory tests to maximize both sensitivity and specificity while providing quantitative information needed for treatment monitoring. All pregnant women receive screening regardless of risk factors because syphilis infection often remains asymptomatic during early stages, and the consequences of missing infection are so devastating for both mother and fetus. This universal screening approach recognizes that traditional risk-based screening misses significant numbers of infected women. Non-treponemal tests, including RPRO, Rapid Plasma Reagen, and VDRL, Venereal Disease Research Laboratory, serve as initial screening tools because they provide quantitative titers that allow monitoring of treatment response over time. These tests detect antibodies against cardiolipin, a lipid antigen that becomes elevated during active syphilis infection. The quantitative nature proves crucial because successful treatment should cause titers to decline predictably, typically showing a 4-fold decrease within 6 months of appropriate therapy. Treponemal tests including TPPA, treponema pallidum particle agglutination, and FTA-APSI, fluorescent treponemal antibody absorption, detect antibodies specifically directed against treponemal antigens rather than the nonspecific cardiolipin antigens. These tests serve as confirmatory tests because they remain positive lifelong after infection, even following successful treatment, making them unsuitable for monitoring treatment response, but excellent for confirming that positive non-treponemal tests represent true syphilis infection rather than false positive results. Documenting treatment adequacy becomes essential because inadequate treatment during pregnancy can result in treatment failure, reinfection, or persistent fetal infection despite apparent maternal cure. This documentation must include the specific antibiotic used, dosage, route of administration, and completion of the full treatment course. Neonatal syphilis diagnosis requires careful interpretation of serologic results because passively transferred maternal antibodies can create diagnostic challenges that complicate the distinction between infected and uninfected infants born to seropositive mothers. Comparing maternal and infant titers provides the most reliable diagnostic approach because infected infants produce their own antibodies in addition to receiving maternal antibodies, resulting in higher titers than would be expected from passive transfer alone. When the infant RPR titer is 4-fold higher than the maternal titer, this strongly suggests active infant infection because passive antibody transfer alone cannot account for this difference. The comprehensive evaluation for suspected congenital syphilis must assess multiple organ systems because of the multi-organ involvement characteristic of spirose heat infection. Complete blood count with differential helps detect anemia and thrombocytopenia that commonly accompany systemic infection. Liver function tests identify hepatitis that occurs frequently in early congenital syphilis and may be the only biochemical abnormality in otherwise asymptomatic infants. Long bone X-rays provide objective evidence of infection through the characteristic metaphyseal and periosteal changes described earlier and may represent the only abnormal finding in some cases. CSF VDRL testing offers high specificity for neurosyphilis, but suffers from poor sensitivity, meaning negative results do not rule out central nervous system involvement. However, positive CSF VDRL results provide definitive evidence of neurosyphilis that mandates extended treatment duration. Placental examination can reveal the characteristic inflammatory changes and may demonstrate spirochetes on special staining, providing direct evidence of infection. Dark field microscopy of suspicious lesions can directly visualize spirochetes, though this technique requires immediate processing and experienced interpretation to avoid false results. Treatment decisions for congenital syphilis require careful assessment of infection probability and risk stratification because the consequences of undertreatment far outweigh the risks of overtreatment in this population. Proven or highly probable congenital syphilis demands aggressive treatment with aqueous penicillin G at 50,000 units per kilogram intravenously every 12 hours for infants under 7 days old, increasing to every 8 hours for older infants. This intensive regimen for 10 days ensures adequate central nervous system penetration and spirosheet killing throughout all body compartments. The critical requirement that no doses be missed reflects penicillin's time-dependent killing mechanism and the need to maintain continuous bactericidal levels to prevent treatment failure. Possible infection with normal evaluation represents the scenario where maternal treatment was inadequate or uncertain, but the infant appears normal, and evaluation results are reassuring. benzathine penicillin G at 50,000 units per kilogram intramuscularly as a single dose provides adequate treatment for this lower risk situation while avoiding the complexity and risks associated with prolonged intravenous therapy. Less likely infection scenarios occur when mothers received late treatment during pregnancy but may not have achieved adequate cure before delivery. The decision between single-dose treatment versus full 10-day therapy depends critically on the reliability of follow-up care. If close follow-up can be ensured, single-dose treatment with careful monitoring represents acceptable management. However, if follow-up is uncertain, the devastating consequences of missed infection mandate full 10-day treatment to ensure adequate therapy regardless of follow-up compliance. Long-term follow-up monitoring ensures treatment success and detects treatment failures that could result in progressive complications if left unrecognized and untreated. Serial RPR titer monitoring provides the primary method for assessing treatment response because successful therapy should produce predictable declines in non-treponemal antibody levels. Titers should be checked every 2 to 3 months and should show progressive decline, with most infants achieving 4-fold decreases by 6 months and non-reactive results by 12 to 18 months of age. This timeline reflects the natural decay of both treatment-responsive antibodies and any remaining passively transferred maternal antibodies. Rising or persistently elevated titers indicate either treatment failure or possible reinfection, both scenarios requiring immediate reevaluation, including repeat CSF examination to assess for neurosyphilis development. Retreatment with the full 10-day intravenous regimen becomes necessary because partial treatment may have selected for resistant organisms or failed to achieve adequate tissue penetration. Neurosyphilis requires specialized monitoring with CSF examination every 6 months until cell counts normalize and CSF VDRL becomes non-reactive. This extended monitoring period reflects the slower response of central nervous system infection to treatment and the serious consequences of inadequate therapy in this privileged anatomic site. Public health reporting to the health department serves multiple crucial functions, including contact tracing to identify and treat sexual partners, surveillance to track disease trends and treatment outcomes, and ensuring that cases receive appropriate follow-up care through public health nursing services when needed. This reporting also contributes to broader epidemiologic understanding that guides prevention strategies and resource allocation. Parvovirus B19 represents a unique congenital infection that demonstrates how viral tropism for specific cell types creates distinct clinical patterns compared to the other congenital infections we've discussed. This virus shows particular affinity for rapidly dividing cells, especially red blood cell precursors in the bone marrow, which explains its characteristic effects on the developing fetus. The transmission pattern through respiratory droplets makes this infection particularly common in community settings like schools and daycare centers, where pregnant women may encounter infected children who are shedding virus before they develop the characteristic slapped cheek rash of fifth disease. This timing creates challenges because the period of highest infectivity occurs before the infection becomes clinically apparent. When maternal infection occurs during pregnancy, the virus crosses the placenta and targets fetal red blood cell precursors, causing profound fetal anemia. The developing fetus depends on rapid red blood cell production to meet the demands of growing blood volume, so when parvovirus disrupts this process, severe anemia develops quickly. This anemia can progress to hydrops fetalis as the fetal heart struggles to maintain adequate oxygen delivery, leading to congestive heart failure, fluid accumulation in body cavities, and ultimately intrauterine fetal death if the anemia becomes severe enough. The remarkable aspect of parvovirus B19 infection is that neonatal disease remains rare even when fetal infection occurs. Most infected fetuses either recover spontaneously as their immune systems mature and clear the virus, or the infection resolves without causing permanent damage. This self-limiting nature distinguishes parvovirus from other congenital infections that typically cause progressive damage. Diagnosis relies on detecting maternal IgM antibodies that indicate recent infection, combined with fetal middle cerebral artery Doppler studies that can detect the increased blood flow velocity that accompanies fetal anemia. Treatment involves intrauterine transfusion for severe cases where fetal anemia threatens survival, though most cases resolve spontaneously without intervention. Zika virus emerged as a major public health concern when the connection between maternal infection and severe birth defects became apparent during the 2015-2016 epidemic in the Americas. This mosquito-borne flavivirus demonstrates how new infectious threats can rapidly create devastating consequences for developing fetuses through mechanisms that weren't previously recognized. The transmission patterns involve both vector-borne spread through Aedes aegypti mosquitoes and sexual transmission, making prevention more complex than simple vector control measures. The sexual transmission route means that even travelers returning from endemic areas can transmit infection to pregnant partners, extending the geographic reach of the virus beyond areas with active mosquito populations. Congenital Zika syndrome represents a constellation of birth defects that reflect the virus's particular tropism for developing neural tissue. Microcephaly occurs because Zika virus infects and destroys developing brain cells during critical periods of brain growth, resulting in abnormally small head circumference and reduced brain volume. The brain calcifications appear as scattered deposits throughout brain tissue, marking sites where viral infection caused cell death and subsequent calcium deposition. The eye abnormalities range from focal scarring to complete retinal destruction, occurring because Zika virus can infect retinal cells during development. Arthrogryposis, characterized by joint contractures and limited range of motion, results from neurologic damage that affects muscle development and joint mobility during fetal growth. The diagnostic approach combines RT-PCR testing that can detect viral RNA during active infection with serologic testing for antibodies. However, serologic testing faces challenges because Zika virus shares antigenic similarities with other flaviviruses like dengue, creating potential cross-reactivity that complicates interpretation. The absence of specific antiviral treatment means prevention becomes paramount. Vector control measures targeting Aedes mosquito breeding sites provide the primary defense, along with personal protective measures like insect repellent and protective clothing for pregnant women in endemic areas. West Nile virus represents another member of the flavivirus family that can cause congenital infection, though fortunately this occurs much less frequently than with Zika virus. The rarity of congenital transmission suggests that West Nile virus either has limited ability to cross the placental barrier or that maternal infection typically occurs outside the vulnerable periods of fetal development. When congenital transmission does occur, the clinical features show considerable variability, reflecting the unpredictable nature of this infection during fetal development. Some infected infants may appear completely normal at birth, while others develop various combinations of neurologic abnormalities, growth restriction, or other systemic manifestations. This variability makes clinical recognition challenging because there's no characteristic syndrome that immediately suggests West Nile virus infection. The diagnostic approach relies on detecting IgM antibodies that indicate recent infection, though interpretation can be complicated by potential cross-reactivity with other flaviviruses. RT-PCR testing can detect viral RNA during active infection, but may be negative if testing occurs after viral clearance. The timing of testing relative to symptom onset becomes crucial for optimal diagnostic yield. Like other viral infections without specific antiviral agents, treatment focuses entirely on supportive care measures. This includes managing any neurologic complications, providing nutritional support if growth restriction is present, and monitoring for developmental delays that might emerge as the child reaches various milestones. Vector control remains the primary prevention strategy, focusing on eliminating standing water where Culex mosquitoes breed and implementing community-wide mosquito control programs during peak transmission seasons. Personal protective measures become particularly important for pregnant women during periods of high West Nile virus activity in their communities. Lymphocytic choriomeningitis virus represents an often overlooked cause of congenital infection that deserves greater recognition because of its association with rodent exposure, particularly to hamsters and mice that may be kept as pets or encountered in laboratory settings. This arenavirus demonstrates how seemingly innocent animal contact can create serious risks for pregnant women. The rodent-borne transmission pattern means that risk assessment should include detailed history about pet ownership, occupational exposure to laboratory animals, or living conditions that might involve rodent infestation. Hamsters represent a particular concern because they can shed virus asymptomatically. making it impossible to identify infected animals based on clinical appearance alone. When congenital infection occurs, it can produce a devastating pattern of birth defects that bears some similarity to other congenital infections, but with its own characteristic features. Hydrocephalus develops when viral infection disrupts normal cerebrospinal fluid production or drainage, leading to progressive enlargement of the ventricular system. Chorioretinitis affects the retinal layers and can cause significant visual impairment or blindness, while microcephaly reflects direct viral damage to developing brain tissue during critical growth periods. The diagnostic approach combines serologic testing to detect antibodies against the virus with PCR testing that can identify viral genetic material in clinical specimens. However, because this infection is relatively rare and not routinely tested for in most clinical laboratories, diagnosis often requires specialized testing that may delay recognition. The absence of specific antiviral treatment means that management focuses on addressing the individual complications as they arise. Hydrocephalus may require neurosurgical intervention with shunt placement, visual impairments need ophthalmologic management, and developmental delays require early intervention services to optimize outcomes. Prevention centers on avoiding exposure to potentially infected rodents, particularly for pregnant women who should avoid cleaning rodent cages or handling rodents directly. When rodent contact is unavoidable, appropriate protective equipment and careful hygiene measures become essential. Prevention of congenital infections represents one of the most cost-effective interventions in all of medicine because the devastating consequences of these infections can often be completely avoided through systematic approaches that begin before conception and continue throughout pregnancy. Preconception counseling provides the foundation for prevention by identifying risk factors and immune status before pregnancy begins. This timing allows for optimal interventions like completing vaccination series, treating existing infections, and modifying behaviors that increase transmission risk. Women planning pregnancy can receive rubella vaccination if non-immune, complete hepatitis B vaccination series, and undergo screening for infections like syphilis that require treatment before conception. Maternal immunizations during pregnancy protect both mother and fetus through direct antibody transfer and reduced maternal infection risk. The timing of these immunizations matters critically because live vaccines like rubella cannot be given during pregnancy, while inactivated vaccines can be safely administered when indicated. Understanding which vaccines are safe during pregnancy versus requiring pre-pregnancy administration becomes essential for optimal protection. Hygiene education addresses transmission routes that pregnant women can control through behavioral modifications. This includes proper hand washing after contact with children who might shed CMV, avoiding cat litter to prevent toxoplasmosis exposure, and using safe food handling practices. These simple measures can dramatically reduce infection risk when consistently applied throughout pregnancy. Dietary precautions target specific foodborne transmission routes, particularly for toxoplasmosis and other parasitic infections. Avoiding undercooked meat, unwashed vegetables, and unpasteurized dairy products eliminates major exposure sources. Understanding which foods pose risks and how proper preparation eliminates these risks empowers women to make informed choices. Screening programs identify infections early when treatment can prevent transmission or reduce fetal consequences. Universal screening for syphilis, hepatitis B, and HIV ensures that infected women receive appropriate treatment and that infants receive indicated preventive measures at birth. Early treatment of identified infections prevents progression to more severe stages that carry higher transmission rates. Partner treatment addresses the source of infection and prevents reinfection, completing the prevention cycle. Universal screening programs reflect evidence-based decisions about which infections occur frequently enough and cause severe enough consequences to justify testing all pregnant women regardless of risk factors, while other infections require more targeted approaches based on regional epidemiology and cost-effectiveness considerations. Syphilis screening occurs universally during all pregnancies because the infection often remains asymptomatic during early stages when transmission risk is highest. The consequences of missing infection are devastating for both mother and fetus, and effective treatment is available that can prevent virtually all cases of congenital syphilis when administered adequately during pregnancy. The rising incidence makes this screening even more critical. Hepatitis B screening follows a similar universal approach because chronic infection often remains asymptomatic. Vertical transmission rates are extremely high without intervention, and effective prevention through immunoglobulin and vaccination can prevent most cases of perinatal transmission. The chronic nature of hepatitis B infection means that women may be unaware of their status despite years of infectivity. HIV testing uses an opt-out approach where all women receive testing unless they specifically decline, recognizing that many women at risk might not perceive themselves as such based on traditional risk factor assessment. The dramatic reduction in vertical transmission achievable through antiretroviral therapy, cesarean delivery, and formula feeding justifies this comprehensive approach. CMV screening remains controversial and is not universally implemented because no effective treatment exists to prevent transmission, and the majority of infected infants remain asymptomatic at birth. However, this approach continues to be debated as our understanding of CMV prevention strategies evolves. Toxoplasmosis screening varies significantly by geographic region, with some countries implementing universal programs while others use targeted approaches. This variation reflects differences in regional disease prevalence, available treatment options, and healthcare system priorities. Rubella immunity assessment ensures that susceptible women can receive vaccination postpartum to protect future pregnancies, since the vaccine cannot be given during pregnancy itself. This approach prevents the devastating consequences of rubella infection during subsequent pregnancies. Understanding the long-term consequences of congenital infections helps families and healthcare providers prepare for the comprehensive support systems these children will need throughout their development and into adulthood. Neurodevelopmental delays represent the most common long-term consequence across virtually all congenital infections because developing brain tissue shows particular vulnerability to infectious disruption. These delays can range from subtle learning differences that become apparent during school years to profound intellectual disabilities requiring lifelong support. The spectrum of severity depends on factors including the timing of infection, specific pathogen involved, and adequacy of treatment when available. Hearing loss deserves special attention because it often develops progressively rather than being present from birth. Infants who pass newborn hearing screens may develop significant hearing impairment months or years later, making ongoing audiologic surveillance essential. This progressive nature means that families who initially feel relieved by normal hearing tests must understand the need for continued monitoring throughout childhood. Vision impairment can result from direct infection of developing eye structures or secondary complications like glaucoma. These visual problems may not become apparent until children reach ages where detailed visual assessment becomes possible, emphasizing the need for specialized ophthalmologic evaluation and monitoring throughout development. Growth restriction often persists beyond the neonatal period, requiring ongoing nutritional support and growth monitoring. Some children experience catch-up growth over time, while others maintain smaller stature throughout their lives. Understanding growth patterns helps families set realistic expectations while ensuring optimal nutritional support. Behavioral problems can emerge as children develop and face increasing social and academic demands. These may include attention difficulties, impulse control problems, or social interaction challenges that require specialized intervention approaches. Early recognition and intervention can significantly improve outcomes. Learning disabilities often become apparent during school years when academic demands reveal subtle cognitive differences. These children may require specialized educational approaches, individualized education plans, and ongoing support to reach their full potential. The need for special education services reflects the complex, multi-system nature of many congenital infections and emphasizes the importance of early identification and intervention to optimize developmental outcomes. Comprehensive follow-up care for children with congenital infections requires coordinated, multidisciplinary approaches that recognize the complex, evolving nature of these conditions and the need for specialized expertise across multiple domains throughout the child's development. The multidisciplinary team approach acknowledges that no single provider possesses all the expertise needed to address the diverse consequences of congenital infections. Effective teams typically include developmental pediatricians, audiologists, ophthalmologists, neurologists, educational specialists, and social workers who work collaboratively to address each child's unique combination of needs. Regular developmental assessment helps identify emerging delays or disabilities as children reach various milestones, allowing for timely intervention when problems are detected. These assessments must be conducted by professionals experienced in recognizing the subtle signs that may indicate developing problems, since many consequences of congenital infections become apparent gradually rather than immediately. Hearing and vision screening requires specialized expertise and equipment beyond routine pediatric care, because the progressive nature of sensory losses in many congenital infections demands more frequent and detailed assessment than typically provided in standard well childcare. These specialized evaluations can detect changes before they significantly impact development. Growth monitoring extends beyond simple measurement to include assessment of nutritional status, evaluation for endocrine complications, and coordination with specialists when growth patterns suggest underlying problems. Understanding normal versus concerning growth patterns in children with congenital infections requires expertise in these complex conditions. Educational support begins early with special education services and continues throughout the school years with individualized education plans that address each child's specific learning needs. This support often requires close communication between healthcare providers and educational professionals to ensure that medical understanding informs educational approaches. Family counseling addresses the emotional, practical, and financial challenges families face when caring for children with complex medical needs. This includes helping families understand their child's condition, navigate healthcare and educational systems, and access community resources for ongoing support. Early intervention services provide specialized therapies, including physical therapy, occupational therapy, and speech therapy, that can significantly improve outcomes when started promptly. These services require coordination with medical care to ensure that therapeutic approaches align with medical management plans.